All right, hello. My name is Krzysztof Gajos. I am a computer scientist. The work that I will be sharing with you today is co-led with Anupam Gupta, who is a neurologist at MGH, works at the Movement Disorders Clinic, and he is also a PhD in robotics. I should add that my motivation for initially starting the collaboration with Anupam was that I am very interested in accessible computing, particularly for people with motor impairments. Anupam and I discovered that many of the things that we need to succeed in our various fields are actually quite similar. So getting some of my disclosures out of the way, and given that I am already a fourth speaker today, or fifth even, I will only very briefly reiterate that we're all here because we're very interested in developing novel methods of modeling and measuring people's behavior in a manner that is accurate, granular, low burden for the participants, and accessible in that it can be performed with devices and technologies that could be deployed to a large number of people. And reacting to a recent comment about clinical trials, this is one of Anupam's primary motivation. He works a lot with ataxia telangiectasia and several other rare diseases where we may have only 500 patients in the entire country. So designing a clinical trial that actually shows the effect of a therapy is challenging because with such a small N, it will only work if our measurements are very sensitive and very accurate. Now, most of what people have been and will be talking about today is passive digital phenotyping. So the idea is that we instrument people and then people go about their lives the way that they normally would. Meanwhile, the technology is recording their activities and coming up with brilliant insights about their health and well-being. I want to complement the discourse that we have been having here so far by talking specifically about active digital phenotyping. The idea here is that we want sometimes our patients to perform well-specified activities using some specialized software or devices, but these software and devices need to be easily accessible to people, so that we can perform lab quality assessments, interpretable and accurate. But we want to design these assessments in such a way that they can be performed in people's homes, on people's own time, on people's own devices. So these assessments need to both be of the quality that we would hope to see in a laboratory or a professional setting, yet be as accessible and easy to perform as the passive phenotyping. So let me show you one such task and tool that we have developed. This is a tool called Hevelius, and it asks people to perform a set of clicking tasks on the targets of different sizes and targets that move different distances from each other. The task takes several minutes depending on a person's impairment, and we collect complete movement trajectories. And unsurprisingly, these trajectories change a lot depending on people's health condition. And from these movement trajectories, we extract 32 different measures taken from literature that have been previously shown to be informative about various aspects of human motor performance. Very importantly, we report these measures as age-specific z-scores. And probably that's true in many disciplines, but in movement, it is very important to have these z-scores be with respect to one's age, because motor performance changes a lot throughout one's lifetime, both with development and with aging. So again, just to show what kinds of things we can get using this tool, in green here you see highlighted measures where the z-scores are quite large, and when we look at them, we see that this particular patient was consistently undershooting their movements, that they were not able to reach the target in the first sub-movement. They were much slower than other people their age. They made longer and larger number of poses. They had hard time initiating the click once they acquired the target, and they had also harder time releasing the click after they've made it. Those of you who work with movement disorders patients may recognize Parkinsonism. That's indeed what it was. Now, I mentioned the normative data that allowed us to report our results as age-specific Z-scores. These data were collected on Lab in the Wild, a platform I co-developed and co-direct that allows us to perform behavioral research with unpaid online volunteers. We generally use this platform to interact with general population, not specifically patient population, and speaking to motivations that people may have to participate in such studies. In Lab in the Wild, we do not use entertainment like some other research projects, but rather we leverage curiosity and social comparison. So for all of the studies, we tell people, complete the study, and we'll tell you how you did and how you did in comparison to others. So we use this platform to reach out to a larger population from around the globe. We had over 500,000 participants, over 200,000 of whom used the mouse. The primary devices that people used for the study were either a mouse or a trackpad. We found that trackpad data were incredibly sensitive to the differences in hardware. However, mouse data were not. So people using a variety of mice, variety of operating systems, all of those data were quite nicely comparable. So this is the data that we're using. We validated the data by reproducing previously published results about development and aging and motor performance. So just like the others, we found that adults have lower peak speeds than older adults, have lower maximum speeds than younger adults. Children make a larger number of target re-entries than young adults. Then both children and older adults produce more sub-movements than young adults. And overall, we replicated 11 different results from the literature. So we are fairly confident that even though our data were collected in a totally unsupervised setting, that they are valid and informative. So we have normative data. We have data from individual patients that we report as age-specific Z-scores. And first, we deployed Hevelius in a clinical setting where people used it under a clinician's supervision so that we could get clean data to understand the clinical value of the tool. And in our first assessment, we worked with patients with ataxias and patients with Parkinsonism. And we found that we're able to estimate people's clinical scores with high degree of accuracy. For the first line over here, where you see the mean absolute error for bars scores in the dominant arm. Oh, I should mention that bars stands for Brief Ataxia Rating Scale. Another research project from a different team estimated that the mean absolute error for expert clinicians is 0.38 and ours is 0.35. So we are really performing reasonable estimation here. We also looked at how the measures collected by Hevelius could be used to discriminate between patients and controls, and this again worked really beautifully. I particularly want to highlight this row where mild ataxia stands for people who had no detectable impairment in their dominant arm. So their clinical score for their dominant arm was 0, yet when they were using Hevelius using their dominant arm, we're able to pick up enough signal to distinguish them from healthy controls. Now, it works in the lab in a clinical setting under clinician supervision. This is not surprising, but our aspiration is to develop tools that are so robust that they can be used at home on people's own hardware and still deliver robust and accurate results. And of course, the concern here is that once people are not under clinician supervision, they will use the tool incorrectly, they will not exert effort, they will get interrupted, and the data will not be valuable. For our main evaluation, we partnered with Ataxia telangiectasia Children's Project, a rare disease foundation that supports research and families of children with ataxia telangiectasia. AT is a progressive and life-limiting disease, so most of the patients with this disease are pediatric. We redesigned the Hevelius so it could be used entirely at home with careful instructions for when it was appropriate for caregivers to help out and when not. Lots of other elements to make the interaction robust. We recruited 18 children with ataxia telangiectasia and 14 healthy siblings as controls. And we attended an annual meeting of Ataxia telangiectasia Children's Project where many families were present. And at that meeting, we conducted in-person sessions with each of the recruited participants, so that we had one session that was performed on clinicians' hardware with clinician supervision. And then families use the system at home on their own laptops for up to 12 weeks. With this population, with the children population, the mean absolute error for the supervised session that was conducted during the meeting on our hardware with clinician supervision was 0.53. If we look at a single session conducted by patients in their own homes without our supervision, the mean absolute error was larger, 0.57. But if we took a very simple step of taking a median of a small number of consecutive sessions to create single aggregate measurements, the more sessions we aggregated, the lower the errors, of course, and even aggregating just 2 consecutive sessions got us to the same data quality as we got when collecting the data in a controlled, supervised setting. The retest reliability was good when for single sessions and medians of 2 sessions, and as soon as we took median of 4 sessions, we got into excellent retest reliability. We also collected at-home data with other populations. We worked with adults with spinocerebral ataxias, and here the ability to detect the disease was excellent. We also worked with myasthenia gravis and ALS, and here the results were strong, but not as strong as for ataxias. But overall, for 4 different patient populations, 3 adult populations and 1 pediatric population, we're able to get high-quality data in unsupervised home settings. The Hevelius task is not the only task we have. These tasks take quite a lot of time to develop. They are not necessarily novel. They are based on previous practice, but we try to make them really, really robust to unsupervised use in noisy environments with heterogeneous hardware. Another task that we have developed and tested is speech, where people repeat as quickly as possible 3 syllables, pataka, 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 pataka. And by measuring the speech rate, the variability in speech rate, variability in speech volume, we can also get signal that correlates very closely with disease severity. We're also working on a task for measuring implicit motor learning that is specifically designed to detect pathologies of the cerebellum. Now, active digital phenotyping addresses essentially all of the goals that we had. It is accurate, it is granular, it is accessible, it is quantitative, it really can be performed in the wild. It is low burden, but not perhaps low enough. Particularly the pediatric participants were complaining that the task was not particularly pleasant. We did talk with them and ascertain that a little bit of entertainment would help, and indeed in our recent deployments we scatter little pieces of entertainment throughout the task, and it helps. But of course we also recognize the value of passive digital phenotyping, right, which is even lower burden than active digital phenotyping. And with the same cohort with whom we tested Hevelius, the ataxia-telangiectasia cohort, we also deployed the gene-active triaxial accelerometer device on children's dominant arms. And we found a variety of measures that very nicely predicted disease severity. In particular, measures related to activity index, which measures the variability in the power in the accelerometer signal. So those measures had very high test retest reliability. They were very informative about the differences between the healthy participants and the controls, and they were very strongly correlated with the clinical scores of disease severity. However, this study happened to be conducted during the pandemic when none of the children were attending school or attending many other activities. So it was a very unusual situation in which nobody was going to Finland or Italy, right? And all of the families were very, very similar to each other in their lifestyles. We are aware that the measures that we got are sensitive to both the activity intensity, but also to the activity selection. Things will change. If people go to school, participate in camps or other things, we will see fluctuations, not due to the changes in underlying health, but probably due to changes in families' lifestyles. So what we believe we should be striving for, and I believe this is implicit in a lot of your work, but I would like to make it explicit, is that we should really be developing hybrid systems that involve both passive and active phenotyping. So active digital phenotyping is very helpful in the early phases in the longitudinal assessments because it helps us calibrate individuals. We know that different people will have individual biases, and even the keynotes address this. Then passive digital phenotyping, which can run continuously on very granular timescales, can alert us if there is something unusual happening in a person's life. Is there a change? And then active digital phenotyping can again be brought in automatically outside of the clinical session without direct clinical intervention to help us establish whether the change that the passive phenotyping detected was due to change in the underlying health condition or due to some extraneous factor. And if it's the latter, it offers us an opportunity to recalibrate. I would like to close by reflecting a little bit about how the technologies that we develop can be situated in real life. It's something that we sometimes forget to do, but it's important that we do it so that we develop our technologies responsibly, but also so that we develop technologies that actually have high chance of success in real life. So already patient motivation has been brought up before. What do we do so that patients continue wearing their devices so they occasionally, sit down and click or say their patakas? On Lab in the Wild, we motivated participants by telling them something about themselves, but this is not necessarily the best idea for patients, some of whom are facing progressive diseases and the news is not good, and some choose not to see it. Still, they recognize clinical value of these data, and they find it valuable if the doctors use those data and reflect with them on those data on things that are relevant to their own health and well-being. So it is actually quite important that doctors of the patients are engaged with the data that patients collect. However, doctors really do not like seeing ginormous binders of irrelevant data or things that they do not consider pertinent or that are very hard to assess. So I think doctors' buy-in is very important. I think doctors' ability to prescribe a measurement may be quite important. So they are excited about the data. They keep asking for it. They are willing to spend some time with the patients to interpret it, which in turn keeps the patients motivated to collect the data. I also want to point out something that came out in one of our studies with the families of children with ataxia telangiectasia. It's a rare disease, so there's little information. Families rely a lot on communication with one another to understand how to prepare for school, how to prepare for transitions, and so on. However, different children have different health journeys. Not all children progress in the same way, or the same pace, or even in the same direction. Some families really do not want to access information shared by families who are at very different stages because, again, some news is very difficult to process. Good longitudinal phenotyping could allow us to match families with information that was shared by other families who have had similar journeys, who are perhaps one step ahead, so that families can anticipate and prepare for transitions. One more thing that I wanted to reflect on that came out in our studies is that when we develop these tools for clinicians, we often develop them for clinicians, which often creates negative effects in the exam room, because modern clinical practice strives for shared decision-making where there's a lot of conversation with the patient, and patients are involved in the care interpretation of the data and so on. However, we create tools that take a clinician's eyes away from the patient toward the computer, where they do their thing and eventually come back to the patient. Perhaps we should be striving from the very beginning to create tools specifically to support the conversations between the clinicians and patients, so that we support this aspiration of shared decision-making. So with this, I would like to end.
Fantastic talk. Thanks for sharing. For the first part, values, it's called. Have you looked into how these measures could be developed and drug regulators or drug approvals specifically?
One of our collaborators is Biogen, and we specifically, two of our cohorts were recruited with Biogen, and they're specifically looking at values as a possible endpoint for clinical trials. All the way in the back.
Hi there, I'm Hannah, I'm the Finance and Mathematics Department at Harvard. I just wondering, you mentioned that with the various, like, you could sometimes track signal in patients even when the bar score was 0. So I'm wondering how you sometimes get around doing supervised learning with a clinical tool that is itself like stored at times.
Okay, so the question was, we had this result that we're able to detect ataxia patients whose clinical scores in the dominant arm was 0. So how do I do supervised learning if my labeled data say this is not a patient? So we actually had other information about those patients. So they were, for example, genetically confirmed to have the disease or had other symptoms, just no symptoms in the dominant arm. So we're confident that they are patients. And it's not necessarily that they had no impairment in their dominant arm. It's just that that many of the clinician-applied scales are not super granular. They are specifically designed so that there are very discernible differences between 0 and 1 and 2 and 3 and 4. So one promise of digital phenotyping is that we can make these assessments much more granular, that instead of going in half a point increments, we can detect much smaller fluctuations and that we can detect them accurately.
I was wondering, does your platform allow time-of-day specific repeated assessments in a way to look at time-specific disease phenotypes, where you might have in the prodromal state time windows where you might see a differential to a more healthy person, but on other times that patient performs equally to a healthy person?
So we worked a lot with patients with Parkinsonism, and here the symptoms vary a lot throughout the day due to fatigue and also the timing of the drug intake. So in principle, yes, you could use this tool multiple times a day, but for someone with moderate impairment, it takes perhaps 6-7 minutes, and it is substantial effort, so it would require substantial buy-in from the patients. So there, particularly in situations like that, maybe combination of passive and active phenotyping would be extremely valuable, because we could calibrate, but then follow up with passive methods to detect the fluctuations.
Thank you. Let's thank the speaker again.